Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today we are going to discuss about very rare but very important topic in our medical field, that is femoral head fracture. If you are in this video, we are discussing like from basic to advanced concepts in a clear, simple and practical way, whether you are a medical student or an intern or preparing for NEET PG, USMLE or FMGE, this is for you. So let's start. Femoral head fracture. If you're seeing this image, if you're seeing this image, you can see here, this is we call pelvic joint. Okay, this is pelvis joint, and this part we call the femoral head. So this is ball, and this area is look like socket, that is pelvis part, we call that is acetabulum. So this femoral head, ball and socket joint, so this both we call that is ball and socket joint. Okay, so here if you are seeing this image, if any fracture or any disruption happen in this area, that means in femoral head area, then we call that is femoral head fracture. Mostly why this thing happening? Because maybe because of some high energy trauma or because of some associated with hip dislocations. This condition is very rare, this fracture is very rare but very complicated thing. Okay, so in definition, it's a break in the spherical top part of the femur, that means thigh bone, that articulates with the acetabulum with socket. Okay, so the hip joint is a classic ball and socket joint. The ball is the femoral head and the socket is the acetabulum of the pelvis. Mostly the femoral head is articulates with the acetabulum. Okay, if you are seeing the review, we have for this femoral head fracture, we have one classification. The classification we call Pipkin fractures classification. That is very important for diagnosing and for management of this femoral head fracture. Okay, mostly I already mentioned this femoral head fractures is happened by mostly dislocation. So we have two types of hip dislocation, that is posterior and anterior. So how? First, in posterior dislocation of the hip, the femoral head dislocates, and it hits the posterior rim of the acetabulum. What is the posterior rim? Where I can find means, this is femoral head, right? In back side of that gap, we call that is the rim. When because of that high energy trauma, when the trauma happen, automatically that hip femoral head will go back and it will hit the rim, and because of that friction, that femoral head will get fractured. Okay, so that's why posterior dislocation. Because of this posterior dislocation, mostly we can see femoral head fracture. So it's mostly like 90% of cases we can see only posterior dislocation. Okay, next, in anterior dislocation will cause impaction fragment of the femoral head or indentation of the fractures. So mostly we can see posterior dislocation. Okay, so next, mechanism of injury. This thing, mostly this femoral head fracture typically results from high energy trauma, and think of a dashboard injury in a car accident. Okay, and I already mentioned the most common scenario is a posterior dislocation of the hip, where the femoral head is pushed out and breaks. Okay, in mechanism of injury we can see high energy trauma, and like MVA, and like vehicle accidents and dashboard injuries I already mentioned, and fall from height, and posterior hip dislocation with axial load and a fixed hip, like this is most common scenario, and sometimes like anterior dislocation also, but anterior dislocation we can see it's like very rare conditions. Okay, next, in anatomy review, first of all we have to understand little basic anatomy for this thing. Okay, here you can see pelvis. In this pelvis, the pelvis is attached with the femoral head. That femoral head and that pelvis also we call that is ball and socket joint. And here most commonly we have to understand one point. This femoral head have some different parts of the bone, like femoral head and femoral neck, and we can see intertrocentric area, and this is and greater trocentric area and lesser trocentric area and subtrocentric area. Okay, here mostly we have to focus in this femoral head. Okay, so here, because why I'm always telling about like very important this part, because the fracture happens exactly in this region. Okay, the femoral head is articulates with the acetabulum. Okay, when we are going to blood supply, here mostly we can see that medium circumflex femoral artery. This artery is very important because it can damage and it can lead to avascular necrosis. Avascular necrosis means it's like ischemic necrosis. That means if any fracture happened with this femoral head, means that now that artery, that medial circumflex artery will like passing from there. When that fracture happen, automatic it will, that blood vessel will tear, that medial circumflex femoral artery will tear, and it will cause avascular necrosis, means absence of blood circulation, and it can cause necrosis. Then there we can see ischemic condition, that part will not get enough blood, then it will forms to necrosis. Okay, so this condition we call avascular necrosis. Okay, next, in some stages we can see the ligamentum of teres. This ligamentum of teres, where you can find this ligamentum of teres, we can see in femoral head inside the acetabulum. Okay, the ligamentum of teres also carries some arteries of the femoral head. So when you are getting that fracture, automatically that part will get avascular necrosis. Okay, so that's why this is very important of the blood, this blood supply and these things. Okay, so here in anatomical part, what are the things is important, means the femoral head, it articulates with the acetabulum, and second one, the blood supply is mainly from the medial circumflex femoral artery, and because of that medium circumflex femoral artery, if it's damaged to it, this can lead to avascular necrosis. And ligamentum of teres also carries a small artery to the femoral head. Okay, so next, Pipkin fracture classification. Now what are the things we discuss is like normal, like basic things, but what are the, this classification is very important classification, because now comes, this is the important part, the Pipkin classification. This classifies femoral head fracture based on location and associated injuries. So how many this fractures we can see, means 4 types of fractures based on traumatic events. Okay, this is characterized as like dislocation and fracture of the femoral head. If you are seeing this image, you can see this is the femoral head. In this femoral head, you can see some part of circle, that depression we call fovea capitis. With this fovea capitis, we can differentiate the type of fracture in Pipkin classification. Okay, so now total how many types I told? 4 types. In these 4 types, we have to from type 1 to type 4. That means type 1 is very least severe condition. Type 4 is like most severe condition. Okay, so based on that we are going to do that management and everything. Okay, now Pipkin's classification. First one, type 1. In type 1, the fracture we can see below the fovea capitis, and this fracture is like non-weight bearing area we can see. Okay, in type 1, this is because this happened because of posterior dislocation, and it's like caudal and inferior to the fovea capitis. Okay, so type 1 is the it's not a severe condition. Okay, and this fracture we can see below the fovea capitis, and this is non-weight bearing area. Second one, type 2, is like posterior dislocation. Because of posterior dislocation this fracture happens, and mostly we can see that is the cephalad, that means superior to the fovea capitis, and mostly it involves because of weight bearing surface. How you can understand means, if you are seeing this image, this is fovea capitalis inferior. If any fracture happened here in this area, it will comes in type 1. If up of the superior fovea, this is type 2. Okay, this one type 2 Pipkin classification femoral head fracture, and this one type 1. Okay, now we are going to discuss about very important and very very hard and worse prognosis, and very hard to do surgery, and that for treating purpose it's very hard, this type 3 and type 4. Now type 3, posterior dislocation. Every fracture happened by mostly posterior dislocation. Only anterior dislocation is happened means it's very rare conditions. Okay, so in type 3 posterior dislocation with associated with femoral neck fracture, and do open, and for that fracture we have to do open reduction of hip, neck and head, and never don't do any close reduction. This may displace the neck fracture, and we can do open reduction internal fixation of the head and neck, and through the Watson-Jones approach or Smith-Peterson approach. When we are discussing about the surgery and this thing, that time I will tell you little deep, okay, about surgical things. Next one, type 4. In type 4 you can say like this fracture, okay, in type 4 we can think like type 1 or type 2 plus acetabular fracture. Usually posterior wall we can see this fracture conditions. In type 4, fracture of the femoral head associated with acetabulum fracture. In acetabulum fracture, posterior dislocation can cause acetabulum fracture. Head fracture can cause anterior dislocation. Okay, so this Pipkin classification is very important. Another time I am repeating this thing. Total in femoral head fracture we have one classification, that is Pipkin classification. We have 4 types of fractures. Okay, in type 1 the fracture below the fovea capitis and its non-weight bearing area. In type 2, fracture above the fovea and it's like weight bearing surface. In type 3, it's like type 1 or type 2 we can see plus femoral neck fracture. In type 4, the type 1 or type 2 we can see plus acetabular fracture, usually posterior wall, we can see these things. Okay, so next, clinical presentation. What are the things we can see in clinical features means, first one, pain as usual. In severe in patient usually present after trauma with pain in hip or groin region, and inability to move the leg, that means inability to bear weight, and shortened, flexed, adducted and internal rotation. This is because of posterior dislocation. In hip posterior dislocation we can see shortened leg and flexed leg and adducted and internal rotation. Okay, whenever you are seeing this type of things, then you have to think about posterior dislocation, and we have to check vascular and neurological status, mostly because if any patient got a femoral head fracture, then we have to suspect, always assess for associated sciatic nerve injuries, because that is very common, and always suspect associated injuries like pelvis, knee, head and trauma. Okay, next, when it comes to investigation, in investigation always we have to start with X-ray. In X-ray, anterior posterior AP, anterior posterior view and lateral view, but often that's not enough. Why? In X-ray, this pelvis we can see, if you are seeing this image, you can see some of the dislocation some of the dislocation you can see here, posterior dislocation, and sometimes you can see the fractures. Okay, sometimes you can see the fractures, and we can follow another thing also, that is Judet view. In this Judet view we can easily appreciate the acetabular involvement. Okay, here if you are seeing this image, you have to compare with this both sides, then you can easily find out this Judet view. Okay, next, CT scan is essential to see the fracture fragments clearly. In CT scan, like with 3D reconstruction we can do, and this is essential like before surgery to plan. Okay, and MRI is very rare, and it's like helps in follow up to assess the risk of avascular necrosis and some soft tissue injuries. Now management, very important thing. Management mostly depends on the Pipkin type and the patient profile, and like it's like immediate reduction of hip dislocation, like close reduction, and time is very critical, and greater than 6 hours means this patient is very risk on avascular necrosis will increases. In non-operative, only for like small non-displaced or type 1 fractures with like minimal symptoms, we are not doing any non-operative, but it's very rare, like minimal displaced like type 1 fracture and no intra-articular loose fragments, and patient is non-ambulatory or poor surgical candidate. That means if that is like a very old person, then mostly we are not doing any surgery because that patient can't ambulate in these things. Okay, next one, operative treatment. In operative treatment, like we can do urgent reduction of the hip dislocation and open reduction internal fixation for displaced fractures like type 2 or higher, and we can always we have to fix screw fixation preferred. Okay, and fragment excision like small and non-weight bearing fragments, and total hip arthroplasty like elderly patients and non-reconstructible fractures and femoral head collapse. Okay, and sometimes we have to do excision of fragments. And early reduction, why we have to do early open reduction internal fixation means the early reduction will reduce the risk of avascular necrosis. Now surgical approach, we have total 3 types of surgical approach. First one, anterior Smith-Peterson approach. That means this is very good for direct access to the femoral head. If you are seeing this image, like from anteriorly we have to do incision, and that easily that femoral head, that the pelvis joint will be visible in this approach. Okay, so this approach is anterior Smith-Peterson approach, but mostly in hospital where I am, like actually now I am doing orthopedic department, so here mostly they are following this method. Okay, and second one, Kocher-Langenbeck approach. It's like for posterior hip. It's preferred if posterior dislocation or acetabular fractures. That means if you are seeing this image, the patient is lying down, and we are going to approach from posterior to medial. Okay, coming from posterior to posterior inferior and like in medial part is going. So here this is posteriorly that posteriorly we can approach, and we can do the surgery, and we can correct that, and we can do the reduction. Okay, next one, surgical dislocation technique, also called Gange approach. This thing, it will help for fully visualization in complex cases. Mostly this type of thing we are doing in only pediatrics. In pediatrics cases we can approach this Gange approach. Okay, next, complications. So what are the complications you can see in femoral head fractures? First one, avascular necrosis. We already discussed this thing. Avascular necrosis of femoral head, mostly like 10 to 40% we can see this type of things, and post-traumatic arthritis, and sometimes non-union or malunion, and sciatic nerve injury, and especially we can see the peroneal branch, and heterotrophic ossification and chondrolysis, that means breakdown of cartilage. Okay, and heterotrophic ossification means Yeah, heterotrophic ossification means bone forming in soft tissue. Also chondrolysis means breakdown of cartilage. Okay, next, post-operative care. That means after surgery, what other things we have to do? We have to protect it with weight bearing. Okay, we have to protect it with weight bearing, and we can do early passive mobilization to prevent leg stiffness, and we have to do like serial imaging to monitor is healing or not, and we have to start antithrombotic prophylaxis for because if any large bone fracture happen means it can leads to cause fat embolism. So that's why we have to start antithrombotic prophylaxis for preventing DVT and pulmonary embolism, this type of conditions, and we have to monitor for signs of avascular necrosis. When it's coming to prognosis is depends on type of fracture and age of patient and time to reduction and fixation. And rehabilitation involves early mobilization and physiotherapy, and it's critical for recovering. And yeah, prognosis, the type 3 and type 4 is very hard to like, because it's very we will get like worse prognosis. Type 1 and type 2 is very easy to the prognosis will be good. Okay, so when it's coming to what are the things we discussed, that is in quickly, let's quick revise. Pipkin classification: type 1, type 2, type 3, type 4. This is very important in our exam. And mechanism of injury like high energy trauma and hip dislocation, and this is very like always keep this in mind, because of these fractures mostly we can see risk of avascular necrosis, and early reduction is the key. And know the classification and blood supply, it will help in your exam, and it's like easy marks in NEET, PG and FMG and reassembly. Okay, thanks for watching. If you found this video is helpful, like, share and subscribe for more medical content simplified for you. Comment below if you want a video on avascular necrosis or hip dislocation. Until next time, keep learning and keep growing. So we will meet in our next video. Take care. Bye bye.